Everyone, I'm Dr. Rawan, and today we will be talking about pediatric hemangiomas. In this lesson, we will cover how to recognize hemangiomas, when to treat them, practical management steps that you can use in your clinic. So, starting from the definition, what is a hemangioma? Hemangiomas are benign vascular tumors of infancy caused by endothelial proliferation. The most common form is the infantile hemangioma, which appears after birth, it grows rapidly, and then slowly regresses. Infantile hemangiomas are the most common benign tumors of infancy. That's why I made this video. And they can be superficial, deep, or mixed with components of both superficial and deep layers. They occur mostly on the head and the neck. While the incidence has been increasing lately, it reached 4 to 5% of the infants. The risk factors include female sex, prematurity, and low birth weights. And some research have shown that even hypoxia, perinatal hypoxia, increases the risk as well. The hemangiomas are mostly solitary and harmless, but some require treatment depending on their location, size, or the complication they are causing. There are two major forms of hemangiomas in pediatric population. First, there's the infantile hemangiomas, the ones that we see most commonly. They are typically not present at birth, but they appear in the first weeks, mostly in the fourth week, and they are glucose T1 positive biologically. And the other form is the congenital hemangiomas. They are fully formed at birth. We can see it the moment the baby is born. So what is the life cycle of hemangioma? Well, they first proliferate in the first 3 to 6 months, and then they reach the most growth by the 9 to 12 months. Then they regress after the 12 months and continues over the years. Many of them resolve substantially by age 5 to 10, but can leave residual skin changes. So how do you know that the hemangioma is undergoing the regression phase? When they become softer and more compressible, then the color changes from bright red to purple or gray. The skin may return to normal, but often there are residual changes like excessive fibro, fatty tissues, telangiectasia, and skin laxity. How to diagnose it? Well, clinical inspection is enough. You can see only superficial bright red strawberry lesions, deeper bluish ones, or even mixed. But if you have any doubts, you can order a skin biopsy. If you suspect any visceral involvements, then you can order ultrasound or MRI to see the deeper organs if they are involved or not. This is usually done to rule out associated anomalies and to differentiate proliferating infantile hemangiomas from other tumors. Do we treat all the hemangiomas? Well, no. Most of hemangiomas are observed only. They do not require treatment because they resolve on their own. But when do we treat them? Treatment indications are ulceration, especially in the anogenital area, functional threat if they are obstructing the airway, if they're in the airway itself, if they're in the periorbital space, they may cause vision loss or vision involvement if they're on the ears, so they can make hearing a problem. The cosmetic risk if they are covering a lot of the face. Sometimes if they are involving any visceral organs, then they may cause cardiac failure, and if they are growing in a very fast way. Treatment-wise, we usually use topical timolol for small superficial infantile hemangiomas, and because it's a beta blocker agent, then it works by vasoconstricting first, and then it decreases the vascular endothelial growth factor expression. By doing that, the endothelial cell undergoes apoptosis and the hemangioma goes away. But if there is a complicated infantile hemangioma or systemic involvement, then our first line treatment will be oral propranolol. The typical dose is 2 to 3 milligrams per kilogram per day. We give it twice. We start at a lower dose and then increase it after 24 to 48 hours. This treatment commonly continues for at least 6 months and sometimes even to 12 months, based on the patient's response to the treatment. But there are some watch outs while we use propranolol. When you start propranolol, because it's a beta blocker agent, we need to know the patient's baseline heart rate and blood pressure, because it may cause both bradycardia and hypotension. So if possible, consider ECG, and if it's even possible, to talk with a cardiologist to order an echocardiography. And then avoid starting propranolol in infants with a bradycardia, heart block, or reactive airway, because it may cause bronchoconstriction as well, so it may worsen the case. And please tell the patient's family, the baby's family, to not give it on an empty stomach, because it causes hypoglycemia. So in order not to make it worse, don't give it on an empty stomach. So what are the other treatment options? Laser surgery and sometimes other systemic agents. Laser can be used for the superficial lesions, although it may cause hypopigmentation and scarring. Surgery is another option for residual tissue after regression or selected complicated case. But for refractory or life organ-threatening lesions, then you can use systemic agents like corticosteroids and sirolimus. Well, there is a very important thing in hemangiomas. It's to understand if the liver is involved or not. Now, when do you suspect liver involvement? If there are multiple segmental infantile hemangiomas, or if there is a large facial segmental infantile hemangioma. If these cases are present, then order an abdominal ultrasound to check if there is a liver involvement, if you have a hemangioma there. Why it's important? Because a high vascularized organ like liver, a hemangioma there may cause anemia, thrombocytopenia, or even cardiac failure. So what are the complications and what are the red flags? Complication-wise, we see ulceration is the most common complication, pain and infection, especially in the anogenital area. The airway hemangiomas may cause respiratory distress. Periorbital involvement may cause visual obstruction. And if there is a visceral hemangiomas, they may even cause cardiac failure. So when to hospitalize these patients? If they have respiratory distress, if they have feeding difficulty, especially if it's in the oral cavity or on the lip, if our baby is lethargic, if it's rapidly expanding lesion, or if there is a severe ulceration, because if we have a severe ulceration and it's in the anogenital area, it may even cause sepsis and death. So that's why you have to hospitalize the patient and start the treatment immediately. So as a quick clinical algorithm, if you confirm the diagnosis of infantile hemangioma, we have to assess the risk based on the location, size, and if there is any complication. If we have only low risk, then observe, and then timolol can be used in this case. But if we have a higher risk or functional threat, then we can use oral propranolol and then refer to pediatric dermatology and oncology. If there is already a very high risk like airway, ocular, or heart involvement, then we have to urgent specialized referral would be the best approach. So to sum up, infantile hemangiomas are common. They usually appear after birth. They proliferate in the first months, then they regress over the years. Most of the cases of the infantile hemangioma cases can be observed, but if they are causing any malfunctioning, ulceration, or systemic complications, then we have to start treatment. Topical timolol is effective for more superficial lesions, but in the complicated or problematic infantile hemangioma, we have to use oral propranolol. The typical target is to make the dose 2 milligram per kilogram per day, starting low, and then we titrate it and increase the dose. But while using oral propranolol, we have to monitor for bradycardia, hypotension, and hypoglycemia. Screen for hepatic lesions if multiple cutaneous infantile hemangiomas are there, or if there is a segmental lesions. If you have any complicated case, so please manage the complex cases with multidisciplinary vascular anomalies teams. Finally, if you have any questions, please write them below, and thank you for watching.